This conference will now be recorded.
Welcome, everybody. We're going to be talking about pharmacology, which is going to be chapter 14 in your textbooks. So we're going to be looking at the different routes of medications, different medications that EMTs are going to actually follow within their scope of practice, different administrations. We are also looking at the five rights of medication administration, as well as the sixth right, which is going to be proper documentation of that medication administration. So some key terms when we're looking at the definition of medication, this is going to be a drug or other substance that is used as a remedy for illness. When we look at the definition of drug, oftentimes we use medication and drug synergistically together, but they are different definitions, different meanings. So with drug, this is going to be your chemical substance that is used to treat or prevent a disease and or condition. With pharmacology, this is the study of drugs. And then our pharmacist would be a doctor who specializes in medications and medication administration. So with the definition of administration, when we're looking at the EMT scope of practice, EMT will actually take all the necessary steps to give the patient the proper medication at that proper dose with the proper route, proper indications, ensuring that the contraindications are not met, and then looking for the proper effects as far as medication administration. Again, that's administering medications. Now we are also able to assist. So we're going to prepare that medication and then hand it to the patient, who will then proceed with taking the medication. So a good example of this is as far as nitro. So assisting an individual taking their nitro would be I pour a nitro tablet into my hand, and then I hand that tablet over to the patient. The patient then places it underneath their tongue. Now, if I were to administer nitro to that patient, I would remove the nitro tablet from my medication vial, and then I would actually place that tablet underneath the patient's tongue. So the medications that we're going to be looking at within the EMT scope of practice, and remember with scope of practice, this is always going to pertain to the state that you're working in. And then when you get more specific, it will fall under the organization's medical director of what they choose to allow certain EMTs or paramedics or EMRs, what their scope of practice is within that set medical guidelines with the specific organization. So oxygen is a medication. So oftentimes we overlook that aspect, but we should be going through our five rights every time that we offer or administer oxygen. Oral glucose, aspirin, activated charcoal, inhaled bronchodilator, nitro, epinephrine, and then also Narcan. So first, when we're looking at oxygen is going to be an odorless, tasteless gas. It's going to be administered as a 100% gas concentration. Now, as far as our delivery techniques, that 100% can fall under a couple of different categories. So remember, our nasal cannula is going to be in between 24 and 44% oxygen. Non-rebreather mask is going to be right around 90% oxygen. And then administering with the bag valve mask is going to be in between 90 to 100% oxygen. Now, what we use oxygen for, hypoxia, hypoxemia, so dealing with low oxygen content within the system, and it's not able to go through the capillary beds and actually bind to that patient's red blood cells and then bind to the cells. Dyspnea, that's going to be our difficulty breathing with evidence of respiratory distress. So again, going through our patient assessment, honing in on that respiratory characteristics. Our signs of shock, poor perfusion, heart failure, or with pulse oximetry in our protocols if we see a reading of less than 94%. Our ideal range for that is always going to be in between 94 and 99. So with contraindications for oxygen administration, again, this is all going to be pertaining to your protocol, But in most EMS textbooks, it's going to state that anytime you have an SpO2 of greater than 94% and no signs listed within the indications. So they're really starting to harp on that 94 to 99%, because if we are continuously blasting them with a substantial amount of oxygen, we can cause some negative consequences inside the body. So the mechanism of action, so this is going to be what that medication is actually doing in the inside of the body. So the action is going to be increasing the amount of oxygen that's crossing from the alveoli into the pulmonary capillary. So go ahead and imagine somebody's having difficulty breathing. They're trying to breathe off room air, and room air is 21%. So they're not getting the oxygen that they need inside of their system. They're not having that oxygen go through the alveoli and then into that capillary. So by introducing more oxygen, so we were at 21% on room air, we give them a non-rebreather, now we're flooding 90% oxygen in hopes that now we have more oxygen inside the system that will go through those alveoli and then into the pulmonary capillary, and we can create that proper gas exchange. Our oxygen dose is going to be in between 2 to 15 liters per minute, depending on what oxygen delivery device that we are using. So here, you can see a non-rebreather mask. It's going to be set in between 10 to 15 liters per minute. Our route would then be inhalation, and inhalation is going to be our route for all of our oxygen therapies. Next, we are looking at oral glucose. So what oral glucose is it's a simple sugar found in the blood, and it is the primary energy source for the body's cells. Our indications where we would actually administer oral glucose is going to be a history of diabetes with suspected low blood sugar level or known low blood sugar level. Now, most EMT services in the state of Minnesota and the state of Wisconsin can and will use glucometers in order to check that blood sugar. As well, with that indication, patient must have a patent airway and the ability to properly swallow. Contraindications is if we have an altered mental status or an inability to swallow or protect that patient's airway, or if we know it's a hyperglycemic event in which that patient's blood sugar is actually too high. The mechanism of action for oral glucose is it's going to be absorbed in the mouth, through the intestines, and then eventually that simple sugar is going to get into the bloodstream, and there it is actually going to raise that blood glucose level. Our dose for 1 tube of oral glucose or oral glucose is going to be 15 grams of sugar or 1 tube. So our route of entry when we are administering this is going to be ingestion, because that patient technically is eating it. Now we're going to have quite a bit of sugar that's going to be absorbed through the cheek and then directly into that bloodstream. The rest of that oral glucose will be absorbed through the intestines once that patient actually swallows the remainder of it. Next, we have activated charcoal. So activated charcoal is not commonly used within the EMS scope of practice anymore. It's a fine black powder that is designed to absorb, bind to any ingested poison to that charcoal. So the thought process is that if somebody were to ingest poison, they can then take activated charcoal. That charcoal will bind to that substance. Our indications are going to be poisoning by ingestion. In many EMS services, that indication also states that it's got to be within 1 hour of ingestion. Now, our contraindications can't have any caustic substances, and if the patient can't protect their own airway, then they can't take it as well. It's very similar to our oral glucose. Our activated charcoal is going to be taken via ingestion route. Our mechanism of action is going to be the poison will be absorbed by that charcoal and then carried through the digestive tract and then eliminated in a bowel movement. So think of that substance inside of our system. Activated charcoal is going to bind to it, and as a result of that binding, the body can't actually absorb it. So basically it's a protective bubble around that poison, and so it's going to pass all the way through our GI tract, then eventually leave within a bowel movement. Our dose is going to be in between 25 to 50 grams, depending on our patient. It's going to look like this. So oftentimes you will break that seal on it, shake it together, and then a lot of them actually have straws built in, so that patient will kind of drink it like a charcoal milkshake. Aspirin is a tablet medication, and just like our oral glucose and our activated charcoal, this is going to be taken via ingestion route. Indications is going to be chest discomfort or pain. And again, aspirin is going to correlate to our cardiovascular pain in nature. We're not going to be giving aspirin to anybody who's got some type of pain. It's only designed and made for chest discomfort or pain when we're looking at the EMS scope of practice. Our contraindications, any stroke-like symptoms or severe gastrointestinal issues or a known allergy. So the big GI issues that we're looking at is a severe peptic ulcer or an open ulcer within that GI tract that that patient knows about. Our dose for our aspirin is going to be 324 milligrams. So one tablet of our aspirin is going to be 81 milligrams. So when we administer this medication, it will be 4 81 milligram tablets, making up to that 324 milligrams. Now the mechanism of action is going to be an antiplatelet. So remember, our platelets are going to be the grouping aspect within our blood that actually create clots in order to stop bleeding. So with an antiplatelet like aspirin, it's going to make those platelets slippery. So it allows that blood basically to slide by any type of blockage much easier. So if that patient is having a STEMI or a myocardial infarction, it's going to allow for the blood to flow past that blockage easier. So that's what our aspirin is going to look like. Pour 4 baby aspirin in that patient's hand. They are then going to ingest and then make sure that they chew that up really well. With our inhaled bronchodilator, this is a liquid medication. It's aerosolized and then inhaled by the patient. So this can be in a couple of different forms, where if we're assisting a patient taking their bronchodilator in the form of a inhaler, could utilize that, or if we have nebulizer treatments actually within our scope of practice, oftentimes EMS services will either have the handheld version or the mask version of that nebulizer treatment. We have a metered dose inhaler, so an inhaler that is prescribed to the patient, oftentimes with some sort of respiratory disease, COPD, asthmatic patients, and then our small volume nebulizer. Our indications, we have respiratory distress with bronchoconstriction, so our asthma, our COPD, and then also we can utilize this for our patients experiencing an allergic reaction. So the body is going to constrict those bronchioles, so it's going to be very difficult for that patient to get that oxygen in. And then also it makes it difficult for that patient to get that carbon dioxide out of the system as well. So that patient is going to take what's called albuterol. Albuterol is going to be a bronchodilator. It's going to open up those bronchioles, make it easier for that patient to breathe. Our contraindications, patient who is unresponsive or an altered level of consciousness in which that patient cannot follow proper directions as far as actually taking that nebulizer treatment. The mechanism of action, it's a beta-2 specific medication, which specifically relates to the bronchioles of that patient's system. So this is what that small handheld nebulizer treatment is going to look like. Again, this medication is going to be inhaled. That's going to be your route of entry. So we're going to attach our nebulizer treatment to our oxygen tank, and generally it's going to be set right around 6 liters per minute, or until we see a good mist coming out of that tube. Our nitroglycerin, this is a medication used to prevent cardiac patients with diseases of the coronary arteries that deliver blood flow to the heart. It comes in a couple of different forms, tablet, spray, or powder form. The most common form that we're going to come across is going to be in that tablet form. Our indications for our nitro are going to be chest pain or a cardiac related event. Contraindications, if a patient is experiencing low blood pressure, can't follow commands due to an altered level of consciousness, or can't properly protect the airway, or a patient who has taken erectile dysfunction medication within the past 48 hours. Now, in most protocols, it's if they have taken Viagra within the last 24 hours, they're not able to take nitro. And if they have taken Cialis within the last 48 hours, they're not able to take nitro. Now, this all relates to the mechanism of action. This is a vasodilator, so it's going to dilate those blood vessels in the body. So it reduces the workload of the heart, then decreasing the demand for oxygen by the heart muscle. It's 90% of the time when somebody's experiencing chest pain in a medical related nature, it's due to a lack of oxygen in the heart muscle. So by dilating those blood vessels, if there is a blockage within those arteries within the heart, it's going to allow that blood supply to get past that blockage easier. And as a result, we're going to get more oxygen in the system. Now, again, it is a vasodilator. So that's why we see the contraindications associated with it. So low blood pressure, because oftentimes we are going to drop the blood pressure some. So if they're already in a hypotensive state, and most of our protocols are going to say a systolic blood pressure of less than 90. So if they're already hypotensive, if they're at 80 systolic, we give them nitro, we could actually drop the systolic blood pressure more to the point where they lose responsiveness. Our dose is going to be 0.4 milligrams. This is going to be taken sublingually. So it's going to be placed underneath the patient's tongue and it's going to be absorbed. So for patients who've never taken nitro, it's very important that you guide them through this, because it's going to be kind of second nature. And there's a tablet and it goes in my mouth. I'm either going to swallow it or chew it. Make sure that you tell them that it gets dissolved underneath that patient's tongue. So it's going to be one tablet. One tablet's going to be 0.4 milligrams, or one spray if you utilize the spray. And again, that's going to be 0.4 milligrams within that spray. So next we have epinephrine. So epinephrine is going to be used for allergic reactions. What epinephrine is, it's a medication in a liquid form. It's going to be used to treat anaphylactic reactions. Comes either in a subcutaneous injection or intramuscular, which is going to be our auto injector. Indications, anaphylactic response with hypotension, and then also respiratory distress. Because when somebody has a severe allergic reaction, those are the two main body systems that are affected: the cardiovascular or blood vessel system, and then also the respiratory system. Contraindications, there's none really indicated in the emergency setting. Now, you saw with a lot of our other medications, they always put in if they're allergic or known allergy. Now with epinephrine, nobody's allergic to this because this is a naturally occurring hormone within the body. Mechanism of action, it's going to be a bronchodilator and a vasoconstrictor. Because when somebody's suffering from a severe allergic reaction or anaphylactic reaction, it causes massive vasodilation and bronchial constriction. So basically with epinephrine, what we're doing is we're using it as a trump card, and it's going to eliminate or reverse those two major signs and symptoms. So these are the two forms that epinephrine is going to come in. And as far as epinephrine administration, this is going to be a part of our pharmacology lab when we meet for lab next. On the right-hand side is a new form of EpiPens. So this is very similar to the thought process of an AED, where once you turn on the AED, it tells you exactly what to do. This is that new epinephrine pen. So once you pop the top of it, it is got a recorded message, and it actually walks you through exactly how to administer that epi. Next, we have Narcan. So Narcan acts upon the chemoreceptors to reverse an opioid overdose. Our indications: respiratory depression with suspected opioid overdose, So the signs and symptoms that we're looking for: pinpoint pupils, any environmental conditions, altered level of consciousness with a decreased respiratory drive. The only contraindication that Narcan has is a known hypersensitivity. Now, nobody is allergic to Narcan, but we got to be very cognizant of how we administer this Narcan, because if somebody is addicted to opioids and we completely reverse that opioid overdose, we could actually eliminate all the opioids that are binded to that system. And as a result, we could send them into withdrawals immediately. Our dose is going to be 0.4 milligrams, and we're going to titrate to effect. So for the EMT scope of practice, we can administer this intranasally only. The mechanism of action is it's going to bind and replace the narcotics or opioids that are on the chemoreceptors that are attached to those opioids. So the Narcan is going to bump those off, and then it is also going to block any receptors that were not previously attached with those opioids. That's what Narcan looks like. Comes in a package with 2 milligrams per 2 mLs. So you attach your vial to your syringe that comes in the box, and then you attach your nasal atomizer, and then it's going to be a rapid push inside that patient's nostril so that it mists, and then those medications actually bind to those receptors. Next, we're going to be talking about glucagon. Glucagon is still relatively common, but we're starting to see less and less of it just based on cost. So with glucagon, it opposes the action of insulin, so it raises the concentration of glucose in the blood by promoting glycogenolysis, which is the breakdown of that glycogen. So with our simple sugars within our body, it's got to be broken down into a couple of different components before the body is actually readily able to absolve that energy. Our indications for a glucagon is going to be a hypoglycemic event in which we cannot actually administer oral glucose due to that patient having an altered mental status or not able to protect their own airway. Contraindications: known hypersensitivity. Again, that's a blanket term. Nobody's allergic to glucagon because glucagon, again, is a naturally occurring hormone in the body. Our dose for glucagon is going to be 1 milligram. And then our route is going to be subcutaneous injection. Mechanism of action: it's going to stimulate the synthesis to accelerate that hepatic, bunch of fancy words. It's going to increase the blood glucose level is what we're concerned about. That is how our glucagon comes. So we open up the glucagon kit, and we're going to see a vial with a glucagon powder in it. And then we're going to have a needle that's got a small amount of fluid in it, which is sterile water or saline. So what we do is we remove the vial cap, remove the tip of the needle. So now we have our syringe with our needle attached. We have our vial. We poke the needle through the vial and then push that fluid into the glucagon vial. We swirl up that water so it mixes with the powder, and then we remove that substance from that vial. From there, we're going to go ahead and inject it. And again, the actual process of administering these medications we'll be going over when we meet for lab doing our pharmacology aspect. Now with medications, they have a couple of different drug names. So first, with the chemical name, this is going to describe the drug's chemical structure. So this is usually the first name that is going to be associated with that drug. Next, we have a generic name. So this is the non-proprietary name, usually the generic name that reflects the chemical characteristic of the drug, but shorter. And then our trade name is going to be our brand name. So when we're looking at this, as far as medication like aspirin, so aspirin would be our generic name. And then our chemical name, that is going to be what it's referred to because that is the actual chemical structure that's associated with it. And then our brand name or our trade name would be things like Bayer. So the routes of drug administration, we're going to touch on all of them, not just the ones that we can administer. So sublingual refers to medication that is placed under the patient's tongue and then is absolved. So our nitro tablets and our nitro spray, those are going to be the medications that are administered nitro. When we have oral routes, that drug is swallowed, and our medications that are swallowed are aspirin, glucose, activated charcoal. We also have inhalation. So this is going to be medication in a gas or aerosol inhaled by the patient. So the medications as EMTs that we can give are going to be our oxygen and then also our bronchodilators, either in the form of our metered dose inhaler or a small volume nebulizer. Our intramuscular injection, this is going to be a medication that is directed into a large muscle mass. So when we're administering epinephrine with the use of an auto-injector, that would be IM or intramuscular. When we're administering epinephrine with a needle, that would be subcutaneous. The other routes that were not listed on this slide is intranasal, and again, we are going to be given that with our Narcan administration. So some essential medication information that we have to be going over every time that we go to give these medications. So our indications, contraindications, what are doses, the administration or the route, mechanism of action, any type of side effects. So our indications, the definition of that is it's going to be the most common use of that drug in treating a specific procedure. So when we're looking at the indication of Narcan, we talked about this already, but this should trigger you to think of Narcan. I'm going to use this for an indication of an opioid-related overdose with respiratory depression. Our contraindications, this is going to be situations in which the drug should not be administered because there could be potential harm that could be caused to the patient. So with aspirin, contraindication is going to be stroke-like symptoms because this is an antiplatelet. So if somebody's suffering from a stroke, there could be a potential head bleed inside that patient's head. And so if we administered aspirin, we could make that head bleed substantially worse. Our dose is going to be the amount of the drug given to that patient. So important for documentation purposes. When I write this out, nitro, which our dose would be 0.4 milligrams, I want to make sure that when I document that, I'm writing the number 0.4 and then make sure that you put mg in lowercase in your narrative, and then also within your intervention tablet. Okay. We always document it if it is less than 1 as 0 period and then the number. Then the administration, this is going to be the route and the form in which the drug is given. So the route for our oral glucose, this is going to be ingestion. So this would be a solid as far as the form that it's administered in. And then the actions or the mechanism of action, this is going to be the general effect that that drug has on the body. So again, epinephrine, our mechanism of action is going to be a vasoconstrictor and then a bronchodilator. Any side effects, these are going to be drugs that have actions that are not desired and that can occur in addition to the desired therapeutic effect. So with aspirin, patients could complain of dry mouth and then also some stomach ache or GI issues. So our key steps in administering medications, if we have to, obtain an order for medical direction. So all of our online medical orders must be directly associated to the medical director or a medical physician prior to administering. Offline guidelines or standing orders, we can go ahead and give those medications. So then we're going through the key rights. So first, right medication. If we are assisting in medication with their prescription, verify that it is the patient's prescription. Always check the expiration date, check for any discoloration or impurities, and then we want to verify the form, the route, and the dose. So this should be verbalized when you are working with a partner, so that you say all these things out loud, and then your partner is verifying that yes, all these things are coinciding together. So these are the 5 rights. These are what I'm going to be verifying with my partner. So right patient, right medication, right route, right dose, right time. Then our 6th right would be right documentation. So if I'm going to give a medication and my patient's name is Steven Anderson, and he's having an anaphylactic reaction, I'm going to say to my partner, okay, my right patient is Steven Anderson. My medication is going to be epinephrine. I'm going to give this intramuscular at 0.3 milligrams or 1 pin. It is 3:01 right now. There are no contraindications at this time. And my partner will say, I agree, go ahead and give it. And then with any type of medication administration and pharmacology, we immediately want to be looking for those desired effects after that medication was given. And we will dive in to medication administration much more thoroughly once we meet for lab on pharmacology. All right, that's it for chapter 14, pharmacology. Thanks, guys.